We've arrived at one of the most important topics in all of obstetrics: preeclampsia. And just like this wily submarine, we're on a hunt to find it and catch it before it gets the best of our patient. The reason preeclampsia is such an important topic is that it remains one of the greatest causes of maternal and fetal morbidity and mortality worldwide. While the exact etiology is unknown, the criteria for diagnosis is well established. We'll review the basic criteria now and then delve into some more specifics a little later in the sketch. Preeclampsia, represented by the clamps on these blood vessel looking pipes, is a disorder exclusive to pregnancy. While it affects multiple organ systems, the two main features of the disease are maternal hypertension, represented by this high pressure steam, and proteinuria, represented with our recurring symbol, chicken and yellow fluid, all of which is diagnosed after 20 weeks gestational age. In pregnancy, the definition of hypertension is a systolic blood pressure of 140 millimeters of mercury or higher, or a diastolic blood pressure of 90 millimeters of mercury or higher on two values at least 4 hours apart. While we're talking about hypertension, it's important to distinguish preeclampsia from two other hypertensive diseases that can be diagnosed during pregnancy, which are not part of the preeclampsia spectrum: chronic and gestational hypertension. Chronic hypertension can be diagnosed in pregnancy if the patient has two or more hypertensive values at least 4 hours apart prior to 20 weeks gestational age, which is why our chronic grandfather clock is set to 1900. Gestational hypertension is hypertension in pregnancy that's diagnosed after 20 weeks gestational age and should resolve by 12 weeks postpartum. In addition to the blood pressure criteria, she must not have any protein in her urine and no signs of end organ damage on her labs. That's because if she does, she probably has preeclampsia. So, what exactly counts as proteinuria? The gold standard for diagnosis of proteinuria is a 24-hour urine protein of 300 milligrams or greater in 24 hours, or a urine protein to creatinine ratio of greater than or equal to 0.3. We will remind you of this important number with this Navy credit card that pays for that yummy chicken drumstick. It's got an anchor on it that looks like a 3. Finally, a quick note on another disorder that combines chronic hypertension and preeclampsia. It's called superimposed preeclampsia on chronic hypertension, and it's diagnosed by a new onset of proteinuria after 20 weeks gestational age in a patient who's been previously diagnosed with chronic hypertension. Whew, say that 5 times fast. Anywho, back to our main mission. Preeclampsia affects 2 to 8% of all pregnancies and usually occurs in the third trimester. This is in part because maternal blood pressure tends to drop in the first trimester due to the smooth muscle relaxation effects of progesterone. While the exact etiology of preeclampsia is unknown, what we do know so far is that placental factors play a role in its pathogenesis. More specifically, abnormal placental development is thought to play a large role, and it all starts with the cytotrophoblast, one of the cell types in the placental chorionic villi that invades into the uterus. One major function of cytotrophoblast invasion is to invade into the maternal uterine spiral arteries, also known as remodeling of the spiral arteries. This happens to transform these normally high-resistance vessels into low-resistance vessels, all in the name of increasing blood flow to the placenta because a well-perfused placenta equals a well-perfused fetus. In preeclampsia, something goes wrong with this whole process. The cytotrophoblasts don't invade the spiral arteries quite like they should, which is called abnormal spiral artery remodeling, and it means that arteries don't become a low-resistance conduit like they're supposed to. Because of this, the blood flow to the placenta, and therefore the fetus, is compromised, and researchers think that this placental ischemia causes a release of certain proteins that find their way into the maternal bloodstream and cause endothelial cell dysfunction in mom. Endothelial dysfunction is the culprit for the preeclampsia phenotype, hypertension, and proteinuria. The hypertension is due to dysregulation of vascular tone, and the proteinuria is due to increased vascular permeability. Another feature of preeclampsia is vasospasm, and it's the upstream cause of a lot of organ dysfunction due to the hypoperfusion and ischemia that it causes. However, hypertension and proteinuria are not the only features of preeclampsia. In fact, this endothelial cell dysfunction causes almost all organ systems to go awry in some way, ranging from mild organ dysfunction in some patients all the way to full-blown organ failure in others. In truth, preeclampsia is a spectrum of disease, and the diagnostic nomenclature has sought to reflect that by including a subcategory called preeclampsia with severe features. Severe features means that your patient is showing signs of end organ damage, which is why this alarm is alerting us to severe reactor damage. While preeclampsia is already a dangerous condition, preeclampsia with severe features is even more dangerous. We'll review how to distinguish between preeclampsia and preeclampsia with severe features later on in our assessment section. But wait, if everything has been preeclampsia, what's the main event of eclampsia? Eclampsia is when a seizure occurs in a preeclamptic patient. The word eclampsia comes from the Greek word for lightning. This is because, like lightning, it comes on fast and out of nowhere. This seizure is usually tonic-clonic in nature, but can be any type to qualify as eclampsia. This is an emergency and can swiftly cause both maternal and fetal death. So, there's another hypertensive disorder that's within the preeclampsia spectrum that we haven't talked about yet, and it's called HELP syndrome. Within the spectrum, its severity lies between preeclampsia with severe features and full-blown eclampsia. So, yeah, it's pretty bad. HELP stands for hemolysis, elevated liver enzymes, and low platelets. This syndrome usually presents at earlier gestational ages and progresses rapidly, during which time the patient can develop severe liver dysfunction, coagulopathies, and, as always, can progress to eclampsia with a seizure. As you can imagine, the preeclampsia spectrum can lead to a lot of complications. We're going to symbolize all the maternal complications of preeclampsia on the submarine captain over here. They include pulmonary edema due to increased hydrostatic pressure and low oncotic pressures, represented by these soggy lung lapels, hemorrhagic stroke due to hypertension, represented by the streak of blood on her captain's hat, DIC secondary to a consumptive coagulopathy, symbolized with this dice badge, acute kidney injury that could progress to renal failure, represented with this broken kidney microphone, which is due to vasospasm and intravascular volume depletion, and liver injury, represented by this liver-shaped rupture in her uniform, that's due to liver ischemia secondary to vasospasm. In terms of fetal complications, these are all mostly due to decreased blood flow to the placenta and the fetus. They are intrauterine growth restriction, represented by this small crouching sailor who's being restricted from standing by this desk, oligohydramnios, represented by this little puddle of water underneath him. Did he just pee out of fear? Intrauterine fetal demise, represented by the skull flag on this approaching pirate ship. Placental abruption, which we'll remind you of with this placenta-shaped speaker abrupting off the wall. And a non-reassuring fetal heart tracing, represented by this route tracing map. Preterm birth is also another fetal complication, as many fetuses need to be delivered early due to increasing severity of disease in mom. Oh, watch out! Looks like we've got a premature missile launch on our hands. Okay, now that we've got some background info about this important disease down, let's move on to how these patients actually present. Any pregnant woman can get preeclampsia. However, known risk factors will be detailed on this sailor over here. These include those at extremes of maternal age, less than 20 years old or older than 35 years old, nulliparity, multifetal gestations, and a pregnancy BMI of greater than 25, though the risk increases with higher BMIs. African American women also have higher rates of preeclampsia than their non-African American counterparts. In terms of initial presentation, there are many ways a patient can present prior to getting diagnosed with preeclampsia. Ah! That alarm is reminding us that one way a patient presents is with new onset elevated blood pressures during a prenatal exam, even though they're asymptomatic. Another is that they come in complaining of one of the classic symptoms of preeclampsia: headache, changes in vision, such as flashing lights, scotoma, or blurred vision, and or right upper quadrant or epigastric pain, and then are found to have hypertension. If any of these symptoms persist despite treatment, for example, the headache doesn't go away after giving acetaminophen, then it could be a sign of end organ damage. Finally, a patient can present in a full-blown hypertensive emergency with elevated blood pressures that are difficult to control. One of the most important reasons to assess for preeclampsia risk factors in every pregnant patient is because they may qualify for prophylaxis to try to prevent it from developing. For those who are already diagnosed with preeclampsia, it's important to know what concurrent risk factors they have to get a sense for whether or not they're at risk of the disease progressing to a more severe form. One of the strongest risk factors for developing preeclampsia in a current pregnancy is having had it in a prior pregnancy. Make sure you ask your patient about whether or not they were diagnosed with preeclampsia in a prior pregnancy, and if so, if it was with or without severe features. This is because the more severe the preeclampsia was, the higher the risk of developing it again. Those with chronic hypertension and diabetes have an increased risk of developing preeclampsia, as are those who have late-stage chronic kidney disease and those with lupus and/or antiphospholipid antibody syndrome. In terms of family history, if a first-degree relative had preeclampsia, it puts your patient at increased risk of developing it as well. Now moving on to our objective findings. Blood pressure should be assessed at every office or hospital visit a pregnant patient has. As we mentioned before, the threshold for hypertension in pregnancy is a systolic blood pressure of greater or equal to 140 millimeters of mercury and/or a diastolic blood pressure of greater than or equal to 90 millimeters of mercury. If a patient comes in with a systolic blood pressure of greater or equal to 160 and/or a diastolic blood pressure of greater or equal to 110, they have a severe range blood pressure, and if these pressures are persistent, this is a hypertensive emergency. On exam, you'll want to note if there are any clinical signs of end organ damage, such as crackles on lung exam indicating pulmonary edema, or localizing neurological deficits on neuroexam that could be indicative of a stroke. Typically, the majority of these patients will have diffuse edema due to the low oncotic pressure in their blood vessels. Labs will help you a lot in your assessment of these patients. During their first prenatal visit, all women should have a urine dipstick to screen for protein. Some providers screen women at every visit. A positive screen is a urine dipstick of 2+ protein or more. If the screen is positive, or whenever a patient has new onset hypertension, then you should get a 24-hour urine protein collection. If you need the results faster, a urine protein creatinine ratio will suffice. The threshold to diagnose proteinuria is greater or equal to 300 milligrams of protein on a 24-hour urine collection, or a urine protein to creatinine ratio of greater or equal to 0.3. The serum studies you'll get will help you assess for end organ damage. They're also important in distinguishing between preeclampsia without severe features and preeclampsia with severe features. On CBC, it's important to look at the platelets. Thrombocytopenia is one of the hallmarks of preeclampsia, and it's thought to be due to increased platelet consumption. Note whether or not they're above or below 100,000 per microliter, as below 100,000 is the threshold to qualify for severe features. A creatinine greater than 1.1 milligrams per deciliter also indicates severe disease and is indicative of worsening renal function. You should also check AST and ALT levels to assess for liver function. An AST and/or ALT greater than 2 times the upper limit of normal qualifies for severe disease. It's very important to know the full DDX for hypertension and pregnancy. So we've added in this DDX menu over here so that you can easily come back and remember everything you should consider when a pregnant patient comes in with elevated BPs. Okay, now back to our preeclamptic patient. We'll first go over how to assess mom, and then after that, what you should do to assess for fetal well-being. The primary goals of assessment are to find out which hypertensive disease in pregnancy the patient has, and whether she should be managed as an inpatient or outpatient. As we reviewed earlier, if the patient is diagnosed with hypertension prior to 20 weeks gestational age, they have chronic hypertension. If they're diagnosed with hypertension after 20 weeks gestational age with no proteinuria, they have gestational hypertension. If it's after 20 weeks gestational age and they do have proteinuria, then you have preeclampsia on your hands. If you diagnose preeclampsia, you have to distinguish between preeclampsia without severe features and preeclampsia with severe features. In order to rule in for preeclampsia with severe features, the patient must have proteinuria and meet at least one of the following criteria: a blood pressure in the severe range, a lab value that shows evidence of end organ damage, or a clinical sign of end organ damage. Finally, there's HELP syndrome, which we'll go over more in depth now to help you distinguish it from the rest. Those with HELP syndrome usually present a little more intensely and acutely than those with regular old preeclampsia. These patients have nausea, vomiting, and severe right upper quadrant or epigastric pain due to liver capsule stretching. One of the biggest complications of HELP syndrome is maternal liver rupture and subsequent hemorrhage. You'll distinguish these patients mainly through their labs, which conveniently are all described in the name. H stands for hemolysis, specifically microangiopathic hemolytic anemia, which can show up in the labs a number of ways. 2 out of the following qualify as microangiopathic hemolytic anemia: schistocytes on peripheral blood smear, and elevated serum bilirubin, low haptoglobin, or elevated LDH. Next are E and L, which stands for elevated liver enzymes. Like with preeclampsia, this means that AST and ALT are at least 2 times the upper limit of normal, or even higher. Finally, there's L and P, which stands for low platelets. Again, the platelet threshold is less than 100,000 platelets per microliter. Okay, that's it for the tools used to assess and diagnose mom. So how about the fetus? As you may remember from way back at the beginning of the sketch, preeclampsia causes placental, and therefore fetal, hypoperfusion. This is one of many reasons that fetuses are at risk of multiple complications and even fetal death. Imagine if someone was just slowly decreasing the amount of blood perfusing into one of your patients. Now that's a scary situation. Fetal assessment consists of either a non-stress test or a full biophysical profile. We go over what these consist of in much more detail in another sketch, but keep in mind that these are the tools used to assess for fetal well-being. In addition to antenatal testing, fetuses of moms with preeclampsia should also undergo frequent growth ultrasounds, as all of these fetuses are at increased risk of intrauterine growth restriction. Now that we've gotten a history, looked at the maternal vitals and labs, and come up with a diagnosis, what's the plan, man? First, decide if the patient should be treated as an inpatient or an outpatient. The criteria for outpatient management is that the patient either has gestational hypertension or preeclampsia without severe features. They must also be reliable for follow-up. These patients should have frequent outpatient monitoring of their blood pressure and to monitor fetal well-being. If the patient is diagnosed with preeclampsia with severe features, HELP syndrome or eclampsia, or if they don't have reliable follow-up, then they must be managed as an inpatient until they deliver. As preeclampsia is a multifaceted disease, there are a number of things to consider when deciding on treatment. The big picture of treatment is to stabilize the mother and then, if indicated, deliver the fetus. First, we'll start with blood pressure management. The main goal of blood pressure management is to keep the maternal BP out of the severe range, as in a systolic of under 160 and a diastolic of under 110 millimeters of mercury. It's above these values where the risk of stroke and other organ damage increases. There are 2 instances in which you'd give medication to treat these blood pressures: to bring down an acute sustained spike in blood pressure, or as a standing medication to keep blood pressures below the severe range in patients who have consistently high blood pressures. Options for antihypertensive treatment are labetalol, represented by our alpha and beta divers on this boat, hydralazine, represented by the hydro boat, and nifedipine, represented by this knife one of the divers is holding. In general, IV versions of labetalol or hydralazine are the first-line treatment for the acute spikes, as they act much faster than their oral counterparts. Nifedipine can also be used, but it doesn't come in an IV formulation. You'll likely see oral nifedipine used if the patient doesn't have any IV access and needs antihypertensive treatment immediately. For oral standing medications, any of these 3 agents may be used alone or in conjunction with one another. The main thing to remember with these medications is to check a full set of vitals prior to administration, because you can't give labetalol to a patient if their heart rate is below 60 beats per minute. As with any antihypertensive treatment, you don't want to drop the blood pressure too drastically too fast. This is especially important in pregnant women because you could cause rapid underperfusion of the placenta and the fetus could undergo severe hypoxia and distress, necessitating an emergency delivery. Yikes. While there's no one value that everyone agrees upon as the goal blood pressure, a good rule of thumb is to not reduce the mean arterial pressure, or MAP, by more than 25% over the course of 2 hours. The range you eventually want to shoot for is a systolic blood pressure of 130 to 150 millimeters of mercury and a diastolic blood pressure of 80 to 100 millimeters of mercury. Now that we've gotten our patient's blood pressure down, how about that impending threat of eclampsia still looming over our heads? This is where magnesium sulfate, represented by this magazine, comes in. Magnesium is used for two important reasons. It's the first-line treatment for eclamptic seizures, but more frequently, it's used for seizure prophylaxis. This is done via a continuous IV infusion of magnesium during labor and for 24 hours postpartum. However, magnesium administered at this volume can lead to magnesium toxicity, the worst consequence of which is respiratory depression and cardiac arrest. Early signs of magnesium toxicity include loss of deep tendon reflexes. Dropping O2 sats can be the first sign of respiratory depression. The treatment for magnesium toxicity is to discontinue the magnesium infusion and to administer calcium gluconate. And how about the beast itself? Preeclampsia? The only definitive cure for preeclampsia and its related diseases is to deliver the baby and the placenta. So, deliver the baby. But wait, remember back to our very first Intro to OB video where we talked about how obstetrics is a field that's all about weighing the risks and benefits of intrauterine development versus development in the outside world? This is one of those times, especially because the intrauterine environment is a lot more tenuous than in a normal pregnancy. The American College of Obstetricians and Gynecologists have come up with guidelines that guide delivery planning based off the diagnosis you give your patient. Yet another reason to do a thorough workup and assessment. The following are the guidelines for delivery if the patient is overall stable. Patients with well-controlled chronic hypertension can deliver anywhere between 38 weeks and 39 weeks gestational age, but should be delivered by 39 weeks. Those with gestational hypertension or preeclampsia without severe features should be delivered at 37 weeks. Those with preeclampsia with severe features or HELP syndrome should be delivered at 34 weeks. If the patient and her fetus fall into the window for antenatal corticosteroid treatment to accelerate lung development, don't worry, we'll go into what this means more in another sketch. Then the steroid should be given as long as the patient is stable. If the patient and/or the fetus cannot be stabilized prior to these gestational age cutoffs, as in mom is deteriorating clinically or the fetus is showing signs of distress on electronic fetal monitoring, the fetus may need to be delivered earlier. This is a complicated decision that requires the coordination of multiple teams: the obstetrics team, the high-risk obstetrics team, pediatricians, and anesthesiologists. In terms of preventing preeclampsia, the main prophylactic measure is a daily low-dose aspirin during pregnancy. If the patients have any of the high risk factors for preeclampsia, they qualify for aspirin prophylaxis. You may remember many of these from when you took your patient's past medical history. They are a history of preeclampsia, chronic hypertension, diabetes, renal disease, SLE, APLS, or multifetal gestations. Those who qualify for prophylaxis should take 81 milligrams of aspirin daily starting between 12 and 28 weeks gestational age until they deliver. Ideally, they should start taking the aspirin before 16 weeks gestational age. Okay, let's go over a quick recap of our voyage through the preeclampsia spectrum so far. Our main target was preeclampsia itself, which is hypertension and proteinuria diagnosed after 20 weeks gestational age. It's due to abnormal placental development that ultimately leads to endothelial cell dysfunction and placental hypoperfusion. If the disease is severe enough to cause blood pressures in the severe range or laboratory or clinical signs of end organ damage, this is called preeclampsia with severe features. HELP syndrome is a more acute, severe presentation that falls within the preeclampsia spectrum that has characteristic lab findings: hemolysis, elevated liver enzymes, and low platelets. And finally, eclampsia is preeclampsia plus seizures. The maternal complications we get worried about are pulmonary edema, hemorrhagic stroke, DIC, renal failure, and liver failure. Fetal complications include IUGR, oligohydramnios, IUFD, placental abruption, non-reassuring fetal heart tracings, and preterm birth. In terms of demographics, those at the extremes of maternal age who are nulliparous with an elevated BMI are at higher risk, as are African American patients and those carrying a multifetal gestation. These patients may present with headache, right upper quadrant or epigastric pain, or changes in their vision, which, if persistent, are all signs of end organ damage. On physical exam, remember to check for lung crackles and neurodeficits, both of which are signs of advanced disease. Many of these patients will have edema. The goal of treatment is to keep blood pressures out of the severe range, and labetalol, hydralazine, and nifedipine can all be used. Seizure prophylaxis and treatment is done with magnesium sulfate, but be careful. These high doses can cause magnesium toxicity, which patients with renal disease are extra susceptible to. A sign of impending magnesium toxicity is a decrease in deep tendon reflexes, while magnesium toxicity itself causes respiratory depression and even cardiac arrest. To reverse this, stop the magnesium and give calcium gluconate. In terms of the definitive treatment for these diseases, it's delivery. Remember, if you plan on delivering the baby before 34 weeks gestational age, then give antenatal corticosteroids for fetal maturity. Finally, to try to prevent this from happening in the first place, give low-dose aspirin to those patients who qualify for preeclampsia prophylaxis. And with that, we sail into history.